Welcome to episode 1 of Ask Dr. Mitch, where you guys submit questions to me within our private Facebook group, and I try to answer those the best I can with the information that you give me. I got a new friend here, a skeleton. I figured this would help explain some things later down the line. I don't have a name for him or her yet, so if you have ideas, leave it in the comments below so we could finally put a name on this sucker. But without further ado, let's just get right into it. So I'm bringing up the post that I did, which I got a lot of likes on and a couple comments. So we got 4 main questions that we're going to go over today. The first one is from Meghna. Second one, I got Anton. The third one, I got Mamoud. And the last one, I got Millie. So hopefully I'm pronouncing all those correctly. If not, feel free to correct me. So the first thing, Meghna wants to learn more about correcting pelvic imbalances. Now, I asked her to follow up on this just because that's a loaded question because the pelvis does so much. If we're just talking about the pelvis alone, there's a lot of things that need to happen as far as a movement and stability standpoint, but also your second most mobile joint is your hip joint, and obviously that connects to the pelvis, and then our lumbar spine, which is so commonly injured, also attaches to the pelvis. So I'll just talk about the biggest pelvic imbalance I see just from a clinical standpoint, and then if that spurs any more questions, again, leave me a comment below or just send me a message and we can elaborate deeper on the next episode. So from a pelvis standpoint, the number one imbalance I see is what we would call an anteriorly pelvic tilted position. Now, everybody's pelvis is more naturally tilted, more anterior, but it depends on how much it's tilted. So checking out our skeleton that is unnamed still, if you see from the side here, our lumbar spine has a more naturally lordotic curvature, which means it's just arched a little bit more like this, which then tends to dump the pelvis forward, so there's always going to be some slight pelvic tilt to the front. But if that's excessively tilted, we get what we call an extension compression stabilizing strategy, where if we don't know how to control our lumbopelvic motion, we tend to dump into extension, crank onto our spinal muscles, which causes a lot of compression. But also with that tilted pelvis, it also puts your femur more forward, so you're already more in a hip flexion range. So for instance, if I was going to go into a squat, not only do I feel it in my back because I'm arched, but I'm running out of real estate in the front of my hips, and that's where you can get front of the hip discomfort, low back discomfort, and that's never a fun time. So whenever I see a big pelvis imbalance, I'm usually trying to do 2 things. Restore lumbopelvic motion, so learning how to dissociate movement here. And then the second thing is controlling that, especially when we're going to be in more dynamic or heavier lifts, whether we're at the gym or we just don't want to throw our back out doing laundry. So I'll show you a very simple way you can start correcting this imbalance. And all you need is to sit down. Chair, couch, doesn't really matter where, but you're going to sit towards the edge, sit up nice and tall, and then you're going to grab your pelvis, almost like you're holding on to a big old sandwich. And what you're going to do is try to dissociate that pelvic motion. So what I like to do is pretend my pelvis is a bowl of water. I'm going to slowly dump that water out the front. That's more of that extension. That's where most people tend to be in. And then we want to see if we can slowly dump that water out the back or get that nice posterior pelvic tilt. And then I simply just tell patients if they struggle trying to find this motion, just do about 5 to 10 of these. Again, easy range of motion. Just learn how to move this area of your body, because once you learn it, then it gets so much easier to progress it into higher level exercises. So if you feel like you can kind of tilt forward, tilt backwards, next you're going to tilt backwards, hold that position, and then just stand up, or that would technically be a squat. And then you would squat down trying to hold that position, boom, and then reset. So if I'm tilted forward, posterior pelvic tilt, hold, stand up, hold that posterior pelvic tilt. As we come back down, boom, do that for a good 5 to 10. So correcting pelvic imbalance, it's a broad statement. So if you have any other follow-up questions on this, I'd love to answer it further. This whole thing is just so complex though, so I'm just going after what the most common things are. All right, so number 2 question we got from Anton here. I recently developed pain in my foot. I'm pretty active. I go to the gym 2 to 3 times a week and play an hour of tennis as well. Nice, so I love how active you are. I recently started swapping one of the gym sessions with badminton, so I might have a stress fracture or just a stress injury of some sort. I did some reading and I'm not sure whether it's metatarsalgia, say that 10 times fast, or neuroma. The pain region is in a line that goes from the ball of my foot towards the pinky, but it's parallel to my toes. I've done very little walking since I started feeling the pain at every step, but 3 to 4 days in, I've seen no improvement, which isn't good. What would you recommend? Rest, an x-ray, anti-inflammatory pills / ointments? Thanks in advance. So there's a lot of moving parts here. First of all, love how active you are. This is how I want all of my patients and clients to be. But we might have overdone it somewhere along the line, which is why you're feeling the symptoms. Let's see. As far as stress fracture, anything is possible, but if you had a stress fracture, you wouldn't be able to put much weight on that sucker. So as long as you're able to walk around, even if it's painful, if you can put full weight into it, just know stress fracture is unlikely, but anything is possible. Stress injury, again, I like where your head's at based on how active you are. It just depends on when did it start. So you gave good info. So reading through this again, was it during that badminton session when it started? Did it kind of randomly start on its own? The mechanism of injury is super, super important. So if it started randomly, odds are it's not a stress fracture. But if we felt it during, especially badminton, if we're like planting or driving off and you felt something there, then a stress injury is definitely likely. Now, as far as the symptoms, now you mentioned the ball of the foot to the pinky toes. So ball of the foot sometimes can be referred to this portion here. I don't know if you're referring to the heel, because if you have heel down to pinky, then one thing I would be looking for is your mobility on that foot. So in a seated position, I'll show the stretch here on myself. Use your good side first, and what you're going to do is grab your foot and then try to isolate between the metatarsals here and seeing how well it moves on your good side. You should have a little bit of springiness back and forth. Obviously, you shouldn't feel any pain. And then if we went to the other side, start at your big toe, work your way down. Does it start to get really, really stiff here and then stiff and painful? That might tell us it's more of a joint mobility issue where the joints are locked up and not moving the way they should. So sitting down here, let's just go with my right foot. I'll even take the sock off, won't charge any extra for that. So if I just have my foot here, what I would do is grab the long bone or the midfoot right here, and then grab the second one, and then I would just try to shear back and forth. If you have trouble bending over, you can sometimes just go over the top, and I think of like wringing out the midfoot, and then you just work your way down until you get to the outside. So for me, I mean, I don't have any toe issues right now, but if you're going through here and you have a lot of discomfort, especially if you grab the pinky toe here and move it, and it's super stiff, but also it makes you want to bring a tear to your eye, then you definitely could have more of a stress injury on the bone or the joint. It's tough to say without doing a full physical exam, and I would need a little bit more info on how it started. Was it random? Did you feel something in the moment, like pop? Those are super, super important when trying to diagnose exactly what's going on. Now, just given the info that I have from you, I would say couldn't hurt to get an x-ray. I mean, if you're walking around, likely it's not fractured. Trust me, I've had a fracture before. You can't put any weight without, screaming at the top of your lungs. But everybody's pain tolerance is a little bit different. So if you have a high pain tolerance, then I would say you gotta cut back on, especially the tennis and the badminton, any ballistic, especially lateral movements where you're gonna be pressing on the foot and then driving off that outside, especially if those things cause you an increase in symptoms, then no, you probably gotta take a short break from that. The first thing I would test is just that foot mobility, especially compared to your good side. Is there a lot of stiffness? Then actually I might be doing foot mobility drills to help loosen that up. And if that's the case, I have a routine that I recommend to a lot of my patients that I could link in the description as well. All right, 2 questions down. On to the next one. Mamoud, I would love to know about what else I can do to improve mobility and reduce low back pain. All right, this is something I see all day, every day. We had a quick exchange in the comments just trying to get more information. Mamoud, further clarified that I have a problem with L5 in the facet joints. I've done physical therapy or physiotherapy, 4 different clinics, that's a lot. Chiropractic care, 2 different chiropractors, stretch lab, 4 cortisone injections. Holy smokes. My vitamin supplements include magnesium, glycosamine, curcumin, willow bark, devil's claw. As well, I do stretching at home for 20 minutes, 5 days per week. I see a bit of progress, but my mobility and pain are still at an unacceptable level. Well, I would say so with how much things you've tried. So this is something I see all the time, unfortunately, where people failed a lot of trial of cares, especially in different clinics with different professionals. Number one thing I notice is how much you're doing. Usually when I see that many things, that we're shotgunning it, hoping something works. And when you're doing that many different things, you're probably doing things that are helping, but also doing things that are harming. So then you're kind of like net wash, and that keeps you in those chronic symptoms of pain or poor mobility. So whenever I see someone, whether it's a patient or a client online, I peel it all the way back. So we talk about what's been working well. You said you've seen some improvement, but I don't know if that's with everything combined. Is that just your stretching in the morning? 20 minutes is a long time. I usually never recommend doing anything more than 5-10 minutes because that's usually all you need. So Mamoud, if you were my patient, first you've given me a lot of good info, but I would go over what movements suck. So you say facet joint, so does that mean, oh, it sucks going into extension versus, say, flexion? So what ranges of motion suck? So I would take you through a full movement assessment, seeing where there's any mobility restrictions. Because that's super, super important because that tells us what tissues might be barking the loudest, and then we need to, well, improve mobility and tissue quality in those areas, but also learn how to provide relief by giving offloaded stress to other things. So for instance, low back and hips go hand in hand because, well, we mentioned it with the pelvic imbalance. A lot of people, if they have facet joint injuries, they'll be stuck in this more anteriorly pelvic tilted or that extension compression stabilizing strategy. So you have constant compression here in the low back, which keeps symptoms constant, but also that robs away from your hip mobility. So if I was gonna bend over and pick something up, I'm running out of real estate here, and then I have to overload from the spine. So things we would look at, spinal mobility, of course, especially when it comes to the lumbar spine, but also that pelvic mobility. And then I would be looking above and below. So how's that thoracic rotation? Because that's where a lot of our spinal mobility should be coming from. Also, how's that hip mobility? So if we're jammed above and below, then all that stress tends to translate through the lumbar spine. So those are a couple things I would be looking at. And then an obvious one to most people is core strength and stability. Not necessarily just doing ab exercises like, hey, have you been doing crunches or sit-ups, but can you control, this kind of comes back to the pelvic alignment that Meghna asked, can you first dissociate that movement? So can you control that lumbopelvic movement, and then can you control it while doing certain things? If you can't, then usually the spine will crank for support, and then that will lead to facet injuries and other things like that. But there's a lot of moving parts with your case. So if you wanted to elaborate more, and you could even shoot me a direct message if it's a little easier, what of all the things you tried have helped? How long has this been going on? The time frame is super, super important. So if this has been going on for years, then likely it's not going to be gone after doing a miracle 5-minute mobility routine. This is something that's going to take consistent work. So it just depends on how long you tried each of these interventions. Are the supplements helping? And what have you been seeing improvement with? Is that your 20-minute stretching? What are we stretching? Again, if you were one of my patients, I'd take you through a full mobility assessment and looking for your weakest links. So for instance, if you have poor hip mobility and your spine moved great, I wouldn't give anything for the spine, really. I would be looking at where your biggest limitations are, and if we improve those, then you tend to put less stress through the other areas, especially the lumbar spine, and then we can start to see some improvement, especially as we start to layer it up. So I start simple with anyone I work with, and then we layer it up to more complex things. But yeah, hopefully that helps. It's hard to answer more clinical questions without all the info, so I can only give you a broad and vague overview just based on my experience, but there's a lot of moving parts with everything. Alrighty, on to the fourth and the final question. Millie, I believe this was about shoulders, so let me take a look. I would like to see what you have for shoulders. I've had some pain in my right shoulder the past 6 months. It is much better now. I went to the doctors, they gave me some exercises to do, but I really found some better ones with bands. Okay, nice. I love that you got adventurous on your own. And I really have been using the bands just about every day. Nice, I like the consistency. But since that's the ball and socket, I wonder if you have something up your sleeve you could offer. You know more than I do. Well, we'll see about that. Though I really like the bands, I will use weights, but I feel like the bands are easier on my joints. I've not been very nice to my joints over the years. I've been a very active person. Well, I love that you're active. You can be nice to your joints by doing mobility training, which is what I preach all day, every day. But a couple things. Again, when it comes to shoulders, there's a lot of moving parts. And I don't have a lot of the specifics. You know, where was the shoulder pain? What was the mechanism of injury? Were you doing something? Was it a random onset? Did we wake up with it? Those go into what tissues could be involved. But if I want to give you an overview of if I have a shoulder case in front of me, what am I looking at? Well, I'll break it down for you. And we got our skeleton here. When it comes to shoulder movement, you already mentioned it, ball and socket joint, but we also have the scapulo-thoracic joint where the rib cage and the scapula have a nice hopefully they have a nice coexistence when they move. And then also we have the thoracic spine. So one thing that's commonly overlooked with shoulder function and anything with shoulder pain is the spine, especially the thoracic spine. So a good thing to do would be just like a movement assessment. So if I'm sitting up nice and tall here, what I'm going to do is I'm going to slouch, and you're going to keep that slouch, and you're going to try to bring your shoulders overhead. I'm already running out of real estate right here, so that tells us just having some of that rounded thoracic spine limits our shoulder range of motion, which is then going to overload the ball and socket joint because we don't have the mobility that we need somewhere else. And then if we sit up nice and tall, usually we can clear this space no problem. That's what we're looking for. So thoracic spine is a big one. I already mentioned it, but that scapulothoracic motion. So when I'm looking at shoulder movement, especially overhead, if we're going into flexion, all that range at the beginning is going through the ball and socket joint. So that's a glenohumeral joint. That's what most people think of when they think of the shoulder. But then we need to get that upward rotation from the scapula. So the scapula has to have that mobility on the rib cage to keep moving, especially when you run out of real estate in the glenohumeral joint. And then lastly, you have to be able to move through that thoracic spine. So just to do this simple motion, we're looking at 3 things. So this is where shoulders get complex because the shoulder joint itself is the most mobile joint in the body. So it has to be mobile but stable at the same time, or else that's where injuries come into play. And then we need to be able to keep the shoulder blade glued to the rib cage, especially as it moves, and then we need that thoracic spine to move. And especially if you work at a desk, 80% of the time, any shoulder injury I see, a large portion is coming from the thoracic spine because we're unfortunately more forward flexion dominant creatures. So we lack mobility here. So you could do anything you want in the shoulders, but if you don't restore your center mobility, then you're going to overload those tissues, and that's what leads to rotator cuff injuries, so on and so forth. As far as bands, I love that you've been doing bands. I don't know what that means exactly though. So what are we doing with the bands? Are we getting the loop bands, or we're just doing some rotator cuff work? Are we having a band and doing some rotator cuff work this way? There's some vagueness there that you can elaborate in the comments, or you can shoot me a message. But just from an overview standpoint, to have healthy shoulders, you need a healthy thoracic spine, so spinal mobility. Also, you need to have the ability to expand through your posterior rib cage. So a lot of times if you get like tight rhomboids or knots in your muscle blades, you have a lot of compression through here. So that's going to keep your rib cage super compressed back here. It's going to be harder for that scapula or the shoulder blade to move. And then obviously that's going to lead to overloading the glenohumeral joint. So you can see if you just have one thing not moving the way it should, it just throws a wrench in the whole biomechanics. So that's where shoulders aren't as black and white. You got to look at the bigger picture when it comes to this. Well, there you have it. There's 4 questions. On the spot, I just wanted to go over them. Again, I have my skeleton here. Hopefully you guys help me name him or her. Maybe we can get a hat, we can decorate it. I don't know yet. The possibilities are endless. This concludes episode 1. Again, a lot of the questions were more vague. I asked some follow-up questions, but if you can be as detailed as possible, it's going to be easier for me to give you a detailed answer. So if you ask a general question, you're going to get a general answer, and that might not be the information you're looking for. So just remember that for next time. So if you have any questions, leave them in the comments below, and I'll answer any questions that I get, especially if they're super, super specific. And I'll keep making these as often as I keep getting questions. So if we want to turn this into a weekly Q&A, or maybe I can go live every now and then so I can get more feedback as we talk back and forth, that's something to consider. Or if this is bi-weekly, again, the possibilities are endless. It just depends on how much you want to know from me. And if you want to know some stuff, I'm going to share some stuff. Until next time, Mob.